Hi, in this module's laboratory interpretation clinical pearl, I want to go through a complete thyroid panel and give you the step-by-step process to identify all the different patterns that are important clinically. So when you look at a thyroid panel, a complete thyroid panel should include all of these. Now, you may not have all of these, but if you have all these markers, you will definitely be able to figure out variations of mechanisms that are happening. So TSH is an absolute must. Total T4, total T3, free T4, free T3, free thyroxine index, T3 uptake, reverse T3, and thyroid antibodies would be what we're referring to as a complete thyroid panel. Of all these, the single most important test is going to be TSH, and then I'd say the next important test of all these would be thyroid antibodies, because ultimately the mechanisms that have the biggest clinical impact with your patients is going to be if they're actually in a hypothyroid state and have TSH elevations. And then some people have the subclinical hypothyroidism or early thyroid destruction inflammation associated with Hashimoto's, where you see antibodies. Now, a lot of people love free T4, especially free T3, because it's the end-stream metabolite, but it's an unstable marker. It fluctuates all throughout the day, even hour by hour. It's not the best marker, even though theoretically, as we look through what actually happens at the end before the receptor binding, it's really associated with free T3. Let's just quickly review some of the very basic concepts. We know we have a thyroid gland. Thyroid gland has thyrocytes. Thyroid stimulating hormone from the pituitary activates the thyroid gland to function. If the thyroid gland is not functioning well, it's injured, it's destroyed, then there's increased amounts of thyroid stimulating hormone that are necessary to try to make those cells that are left to put out more hormone. So high TSH is always an indication of hypothyroidism. Now, there are some people that have low TSH, and the TSH range can vary, from 0.4, but some labs to 4.5, so it's very broad. But anytime we see TSH, let's say below around 1.8 or lower, we have to we always want to suspect if the pituitary is involved. And if the pituitary is involved, you have to have more than just a low TSH. You also have to have a T4 level that's low. So a primary pituitary secondary hypothyroid pattern is when the TSH levels are depressed, and that's leading to, and you must have this, a total T4 that's also below the lab range. So low TSH, low T4, you're thinking of some kind of pituitary-related mechanism. We'll go over the list of things, typically severe stress responses, severe acute injury like surgery, severe trauma, certain medications can cause that. So your TSH is letting you know if the person has primary hypothyroidism. Your TSH and total T4, not free T4, is letting you know that person may have a primary pituitary related issue, secondary hypothyroidism. Now, what's also very important to remember is when the thyroid gland is producing thyroid hormones, 94% of it is T4, 10% of it is T3. It's just a rough estimate. And the TSH and T4 have a feedback loop mechanism. Okay, there isn't a strong feedback loop mechanism just with T3. T3 is not as significantly produced as T4. So when T3 levels drop, you don't really see the TSH levels go up. But if the thyroid gland is injured and not functioning well, and the T4 levels drop, you'll definitely see TSH that goes up. You can still see it if T3 levels are significant enough. If they lost a big portion of the T3 levels, that may impact the feedback loop. But the feedback loop is predominantly with total T4 levels. We're not talking about free, we're talking about total T4 levels. And that means protein bound, mostly protein bound. Levels of thyroid hormones, and that impacts the negative feedback loop. So once the thyroid gland is activated, thyrocytes, T4 is produced, T3 is produced as a negative feedback loop with T4 to regulate how much thyroid stimulating hormone is necessary. This T4 then gets converted in peripheral tissue by the enzyme 5-deiodinase, and there's different 5-deiodinase in different tissues, and ultimately T4 becomes T3, T3 being the main metabolic active thyroid hormone. And then this is happening in peripheral tissues. Majority of it is happening in the liver, but it's happening in muscle cells, happening in organs, it's happening in the brain even. So all these different tissues have some 5-deiodinase enzymes. There's type 1, type 2, type 3, depending on which tissue it is, and they convert the circulating T4 levels into T3. And then at some point, the T3 levels and even the T4 levels lose their binding globulin that's produced when they're synthesized, and the person will have free T3. So there's a couple things to remember. When the thyroid gland is synthesizing thyroid hormones, it is bound to thyroid binding globulin, right? It's bound to a protein. This thyroid binding globulin allows the thyroid hormone to circulate into the bloodstream but not be able to bind to any receptors. So the thyroid binding globulin prevents it from binding to receptors but allows it to be circulated throughout the body. And if thyroid hormones didn't have attachment to thyroid binding globulin, then they would only have a local effect, because as soon as the thyroid hormone is released, it would just have a local effect and really bind to the local tissue. The concept of having thyroid binding globulin is that these hormones can now circulate throughout the body, and at some point, which no one really understands, some of the thyroid hormones eventually cleave off. Some of the thyroid binding globulin cleaves off and then become free hormones, free T3 and free T4. And what you also want to remember is when you look at like total T4, when you look at protein bound versus unprotein bound, 99% of T4 and T3 levels are protein bound, and less than 0.5% are actually free levels of T3 and T4. And the other key thing to understand is that these free T3 and T4 levels don't have a negative feedback loop with TSH. So when you look at your TSH feedback loop, like free T3 levels dropping are not going to, like they're less than 1.5% of total production, they're not going to cause the TSH to go up. It's really when the total T4 levels drop that really you'll see that TSH go up. Now we use the word total T4. Total T4 really means both free and unbound hormones. But if you really look at this, I mean, more than 99% of total thyroid hormones is actually protein bound, and only 0.5% is free. So when you look at a thyroid panel, like when it says total T4, you pretty much are looking at 99% of those markers are being protein bound. So it's really a reflection of protein bound levels of T4 and protein bound levels of T3. So that's how you should always think about total. Just think of it as a protein bound level. Free T3 and free T4 is that 0.5%, that less than 1%. Now these free T4 and T3 levels are where it can actually bind to the receptor, right? So once a hormone becomes free, it can bind to a thyroid receptor, and then as it binds to a thyroid receptor, you get a proteomic response, you get protein transcriptional responses, and then proteins are developed that then impact the metabolic rate. So this is the basic mechanism of normal thyroid function. The pituitary releases thyroid stimulating hormone that activates thyrocytes to produce T4 and T3. The thyroid hormones that the thyroid gland produces are protein bound, reflected on total T4 and T3 levels. It's really the total T4 that impacts the negative feedback loop with TSH. T4 then gets converted by peripheral tissue to T3, and then T3 and even T4 lose their thyroid binding globulin levels. They become free T3 and T4, and then they bind to the receptor. So let's talk about all the different mechanisms, all the things that can go wrong with each one of these steps, each one of these mechanisms when you're looking at a complete thyroid panel. Okay. Now, when we go back to this complete thyroid panel, let me explain a couple of things also to you. The free thyroxine index is just a random calculation of how much free hormones that may exist. When you see it on a laboratory test as FTI or free thyroxine index, it's not a reliable marker. It's just some kind of guess calculation of what their actual free T4 levels are. It'd be better for you just to have the free T4 levels. The reason you'll see it is some panels only include like TSH and total T4 and total T3, and they don't give you the free levels, they just give you the FTI, which is a calculation, but it's not a very reliable indication of what free T4 levels are. There's also another marker called T3 uptake, and T3 uptake is not actual T3 hormones. T3 uptake is another calculation that's done. And T3 uptake is a reflection of how much thyroid binding globulins there are in the system. And it's inversely related. So if there's high amounts of thyroid binding globulin bound hormones, and then you have a low T3 and vice versa. So it's inversely related to that. Reverse T3 is when a person is converting T4 to T3 inefficiently, and they're not able to convert this very well. Instead of making T4 into actual T3 through 5-deadenase, you can have people that make T4 predominantly into reverse T3. That's an indication that they have what's called underconversion. They can't convert T4 to T3. So the reverse T3 can be useful, and then you have the thyroid antibodies. So let's go through with the main types of diagnosis, and I'll put the thyroid panel, and you'll see that on these slides that some of these markers I put highlighted in red, because red is the absolute critical marker to diagnose that stage. So for hypothyroidism, TSH is elevated. Okay, it really doesn't matter what any of these other markers are. None of these other markers can be used to identify actual hypothyroidism, meaning the gland itself is dysfunctioning. The only reliable marker to let you know that the gland is not functioning is TSH. Even if free T4, free T3 levels are low, that doesn't tell you specifically that the thyroid gland is not working. You could have conversion issues. You can have just unreliable fluctuations of free T3, T4, which happen throughout the day all the time. The test you need is TSH. So TSH being the most important test to identify if someone actually is in a hypothyroid state. Now, hypothyroidism, as we all know, is one of the most common endocrine disorders, and actually is the most common endocrine disorder in the world, only second to diabetes, and it's definitely the number one autoimmune disease in the world. Okay, now, clinical pearl: thyroid antibodies should always be screened with hypothyroidism. 90% of hypothyroidism is secondary Hashimoto's. And that's just another thing. As soon as you see these elevations, just know that there's a 90% or greater probability that they have autoimmunity, and that's where the thyroid antibodies come in. And you usually see thyroid antibodies. And the thyroid antibodies can either be TPO antibodies and thyroid globulin antibodies. Now, in the Hashimoto's course, we go into Hashimoto's in great detail, which we're not going to do now. We're just talking about different markers and panels. But either the TPO or thyroid globulin being elevated or being positive is an indication they have Hashimoto's. And there seems to be more common to see TPO antibody elevations versus thyroid globulin, but they fluctuate too. So if like budget is an issue, then just have TPO. If budget's not an issue, run both. And having one positive versus the other doesn't necessarily change your treatment or diagnosis or management. Sometimes you'll see one go up and the other one normalize, and they vary all the time, and they fluctuate and change as the autoimmunity flares up and calms down, right? But if a person has TSH, they're hypothyroid. If they have TSH and have antibodies, then they have if they have TSH and they have antibodies, then they have Hashimoto's. They have the positive antibodies. Now, you should note that with hypothyroidism, T4 and T3 may be low, or they could be totally normal. If someone has normal T4 and normal T3 and normal free T3 and all the other actual peripheral thyroid hormones are normal, and the TSH is elevated, there's still something wrong with the thyroid gland. There was just compensation that occurred by having very high levels of TSH to make those thyrocytes work. And maybe when you saw the levels, their T4 and T3 look normal. So you're not always going to see a normal T4 and T3 that's low with hypothyroidism, but you will see this TSH elevated. So that's your go-to test. Now, hyperthyroidism, which I think I showed you the slide earlier inappropriately, but hyperthyroidism is when there's a severe autoimmune response against the thyroid gland that's now causing increased thyroid hormones in the bloodstream. Okay, and in hyperthyroidism, TSH is low, and TSH is going to be low in people on thyroid hormone medication as well. But the key mechanism of thyroid hyperthyroidism is there's two things happening. There's an autoimmune destruction of the gland, and in things like Graves' disease, you have also antibodies binding to the thyroid receptors, causing increased activation and production. But the fundamental mechanism of hyperthyroidism, the autoimmune destruction, is so severe, as the tissue breaks down for the thyroid gland, T4 and T3 levels are elevated, and the TSH levels are depressed. So total T4, free T4, even free T3 could be normal, elevated, and the key thing is to see the overactive thyroid hormone levels, low TSH, and you're going to see symptoms of hyperthyroidism. You're going to see anxiety, palpitations, nervousness, tachycardia, all the things that go with it. Okay. Now, when you look at hyperthyroidism, or you look at autoimmune thyroid reactions in general, the key feature of Graves' disease is they have TSI antibodies, and TSI stands for thyroid-stimulating immunoglobulin antibodies. And they bind to the receptor. They're also known as TSH receptor antibodies. So TSI antibodies and TSH receptor antibodies are the same thing, just depends on what the lab is referencing them as. But these are antibodies that are actually activating the receptor sites for TSH, leading to increased production of thyroid hormones. At the same time, TPO, which is the enzyme in the thyroid gland that's used to make synthesize thyroid hormones, and thyroid globulin, the fundamental key structure of thyroid hormones is being attacked. So with Graves' disease, you have these autoantibodies, and it's a hyperthyroid response. Now, when you look at Hashimoto's can be hyper or hypothyroid, right? Once you get Graves and you have the TSI antibodies, you're going to be in a hyperactive state because these autoantibodies in Graves bind to the receptors and increase metabolism. In Hashimoto's, you don't have the TSI, thyroid stimulating, or TSH receptor antibodies involved. You just have the TPO and thyroglobulin. So that's one of the key differences between Graves and Hashimoto's. In conventional thyroid evaluations, if someone is in a hyperactive state and they run, let's say, TSH receptor antibodies, TPO and thyroglobulin antibodies, if the TSH receptor antibodies are there, there's a very high probability that it's Graves' disease, like greater than 85%. And if the thyroid stimulating receptor antibodies or TSI antibodies are normal, then it's a greater probability that it's Hashimoto's. Now, when you look at hyperthyroid Hashimoto's, you'll have the same antibodies, and in this case, you'll have the TSH levels low and the T4 and T3 that are high. So the main difference between Hashimoto's and Graves could just be these elevation of TSI antibodies and TSH receptors. Graves' disease is always much bigger concern because their hyperactive state can increase their metabolic rate. They can damage their heart, especially the valves in their heart and the muscle activity, muscle tissue in the heart. They can end up in a thyroid storm and have some serious shifts in their general function and their autonomic functions from being in that increased metabolic rate. And they can even stroke out. So there's always those concerns as they get into severe thyroid destruction, which is then referenced as a thyroid storm, right? Now, there are most people that have Hashimoto's, I should say, that have TPO and thyroglobulin antibodies that are positive, end up having slow destruction of the thyroid gland over a period of time, and they never actually get hyperthyroid symptoms. So this is the most common cause here. People that have TPO thyroglobulin antibodies, and they just have, over a period of time, enough thyroid gland destruction where their TSH levels go up, and then they have Hashimoto's hypothyroidism. So those that have low TSH, high T4 and T3, and a very acute destructive flare-up of Hashimoto's can be in a Hashimoto's thyroiditis. That's a hypothyroid response. So those are the terms that are used: Hashimoto's thyroiditis, Hashimoto's hypothyroidism, and then we have the whole Graves pattern. And then Graves, eventually leads to the severe destruction of the thyroid gland, and they can end up with, hypothyroidism after their event. Okay. And then there are some people that do react to T3 and T4 antibodies, and there's some labs that actually measure T3 and T4 antibodies. Like in the U.S., Quest Labs measures T3 and T4 antibodies, and sometimes these people have severe reactions when they try different thyroid hormones. So you should be aware of that as far as autoimmune reactions. The other thing that's being illustrated on this slide is, once you see one autoimmunity, you suspect more. And with individuals that have Hashimoto's or Graves, you definitely want to look for celiac potential markers, transglutaminase endomycin antibodies. A large percentage of people that have autoimmune thyroid disease also have intrinsic factor blocking antibodies or pernicious anemia, and high associations with neurological demyelation, so myelin basic protein. And then there's also many people that have Hashimoto's reactivity that develop type 1 diabetes, so GAD65 islet cell antibodies can be useful, and then anti-ovarian antibodies, especially for the history of infertility. Typically what I do is I just do Cyrix-Ray 5 if they have it, and we can screen for all these different tissues, 24 tissues all at once. But that's your basic hyperthyroid response. So simply put, if TSH levels are high, then you would suspect that they're hypothyroid. And if they're hypothyroid, still run the antibodies because they are likely Hashimoto's hypothyroid, and these being positive let you know there's an autoimmune origin. And when you look at if 90% of people have Hashimoto's, what happens to the other 10% of people that are hypothyroid? Those are typically patients that had a viral infection of the thyroid gland that was destroyed, or they had radiation destroy their thyroid gland, or they had a big tumor removed off the thyroid gland, like a big nodule, and they became hypothyroid. But the most common cause is actually this hypothyroid pattern. So you definitely want to look at those antibodies. And also remember that sometimes TSH levels can fluctuate up and down, and you suspect someone may have thyroid issues, even though their TSH is normal, make sure you run the antibodies. And those are concepts that we went into great detail in Hashimoto's course. And if you're working with chronic patients, you definitely want to make sure you understand all the different concepts of Hashimoto's, because it's the most common autoimmune disease. And as you already know, many patients walk in already diagnosed hypothyroid, not knowing they have an autoimmune etiology. So it's important to look at that. Now, moving on from autoimmunity, let's get into these pituitary patterns. A pituitary pattern is the TSH is low and the total T4 is low. So basically, there's not enough thyroid stimulating hormone activity to help synthesize T4. And with lab ranges, which you'll typically see, is the TSH levels are below 1.8 and the total T4 levels are below the lab range. You can look at functional ranges, but for the most part, when these are really there, they're going to be outside the lab range. TSH is going to be within the normal reference range. So you look at T4, and if you look at T4 levels closer to the end of the lower range, the last 25% of T4, you may suspect that they may have that. And with these pituitary patterns, here's a chart I made for you that looks at what the mechanisms may be that can cause that. So TSH less than 1.8 with the total T4, that's low. You would look at very active stress responses. And when we say very active stress responses, we mean like severe overtraining syndrome, severe stress to the point they're not sleeping, they're not functioning, they're not recovering. I mean, everyone has stress. So it's got to be significant stress that's causing it, a dramatic physiological stress response, not just the fact that they have a little bit of stress because they have a project to do. Okay. Medication reactions, dopamine agonists, antagonists, glucocorticoids, terotide. These have been medications that can impact TSH. Prolactinomas. Many people have these benign pituitary tumors, and sometimes they get these prolactin surges. That'll suppress TSH. Just severe cytokine surge, severe inflammation. Most of the patients you have probably have some degree of subtle inflammation if they have a chronic condition. But cytokine surge would mean like they have a severe flare-up of an autoimmune response. They have let's say they have ulcerative colitis and had a severe inflammatory response or attack, and that's when they have their thyroid panels measured. That may impact this pathway. Signaling diminished dopamine levels, diminished serotonin levels may have some potential mechanisms there, but you're really looking at really progressed neurodegenerative diseases, not just like a slight neurochemical imbalance. And severe nutrient deficiencies like malnourishment, where it's not just like that they have, not taking a multi every day. It's where they're actually losing body weight and have malnourishment from, let's say, villus atrophy if they have celiac or something very significant like that. So those are the patterns that may impact TSH. Now, another pattern that can occur, unrelated to pituitary issues or hypothyroidism issues or hyperthyroidism, is a change in thyroid binding globulin levels. So if you remember, thyroid hormones are bound to protein and they have to become free to bind to a receptor site. And when you have a person who's got elevated thyroid binding globulins, then their T3 uptake will be low. This will be your best laboratory indication that's happening. And if you actually measure the thyroid binding globulins, they can be high or low. But the best marker is actually this T3 uptake to see if this is occurring. And T3 uptake is an indirect measure of binding protein. The T3 uptake reflects available binding sites. T3 uptake is not a measurement of serum T3. Now, what you're going to have to understand about this pattern is it doesn't impact TSH, it doesn't impact total levels. The free levels may be low or normal, whether it's free T3 or free T4, but it's really this T3 uptake that's high. So let me try to explain this concept to you with a diagram. But before I do, also, you could have people that have decreased thyroid binding globulin, where they just don't have as much thyroid binding globulin in the system, and you can see that T3 uptake level that's high, right? So take a look at this chart here. This is an indication of 3 different patterns, but they all have the same amount of thyroid hormone synthesis. They all have 9 little boxes. Think of each of these boxes as their thyroid output. So the large boxes are indication of their thyroid hormones, and the small boxes are an indication of thyroid binding globulin binding to them. Okay, So normally you can see here we have, mostly thyroid hormones, these large boxes bound to thyroid binding globulin, and just a few free. And if you really look at the numbers, in a normal individual, 99% of thyroid hormones are bound to protein, thyroid binding globulin, and only a few percent are free. Okay. Now there are mechanisms at times where the person will have too much thyroid binding globulin activity, and even though they synthesize the same amount of hormones, like you can see, like 9 boxes compared to normal here, they have more hormones that are bound to thyroid binding globulin and less free. So this isn't a problem with the thyroid gland, because the thyroid gland is producing its hormones. It's just there's physiological mechanisms that increase thyroid binding globulin. And the single most common cause of this will be things like birth control and exogenous estrogens. They increase this thyroid binding globulin activity. So there's a greater percentage of bound thyroid hormones and a reduced percentage of free, and that could be reflected on their free levels, and this will lead to thyroid symptoms. This right here, this mechanism is one of the most common causes why you see some women go on thyroid, go on birth control pills, and all of a sudden have every single thyroid symptom. They look at their T4 and T3 levels, total T4, total T3. They look fine; they're within the normal reference range. And they look at TSH to see if they're hypothyroid. They have normal amounts of thyroid hormones produced, so their TSH feedback loop is going to be fine. So they don't show as hypothyroid. They just have this thyroid binding globulin pattern, and you'll see that reflected with a low T3 uptake. Okay. Now on the other side here, you could have someone who has not enough thyroid binding globulin. They have a higher percentage of free as their decreased thyroid binding globulin levels go down, and you'll see a pattern that looks like that. So the main concept of thyroid binding globulin patterns is it's not that the thyroid gland is dysfunctional. The thyroid gland is doing its job. It's producing thyroid hormones. There's adequate and sufficient thyroid hormone production. That's why their TSH levels are not abnormal. They don't have hypothyroidism. They don't have hyperthyroidism. It's not about the actual quantity of thyroid hormones. It's just the percentages of free to protein bound that are involved. So I made you a summary chart of increased and decreased thyroid binding globulin patterns to help you with the main concepts, just to review things for you. So here you can see increased thyroid binding globulins. T3 uptake is decreased. That's being the better marker. Your free T3, 4 may be decreased, but it could be normal. Total T3 and T4 are almost always, they're normal. TSH is normal. Thyroid binding globulin, if you measure, can be increased. And then thyroid antibodies are negative. Don't confuse thyroid binding globulin with thyroglobulin. Thyroglobulin is a lab marker that is typically used when someone has thyroid cancer as a way, just as a surrogate marker to see if they have more growth, more activity there. That's not the same thing as measuring thyroid binding globulin. So thyroid binding globulin is a test that you can use to look at these increased binding globulin productions. But your T3 uptake is going to be really your most sensitive marker. And then if someone has this T3 uptake that's decreased, you're going to want to look for sources. So certain drugs and medications can do them, put the list here for you, and then estrogens, particularly birth control pills. And in some women, we don't know why some women are more sensitive than other women, but in some women, there's a small population of women that they will immediately get this binding globulin pattern as soon as they go on thyroid. As soon as they go on birth control pills or on replacement. Doesn't matter if it's bioidentical or synthetic. This leads to decreased free fraction of thyroid hormones, and then they have all the thyroid symptoms without actually being hypothyroid defined by high TSH. And then here you can see the decreased thyroid binding globulin patterns, which is not as common. And then I wrote down different mechanisms, testosterone, really high amounts of anabolic steroids, high amounts of androgen treatment, or medications with glucocorticoids. They can impact these binding globulin levels, so there's decreased amounts of thyroid binding globulin. You can also see decreased thyroid binding globulin. People have really progressed liver disease. They're getting some liver cirrhosis. You can see some of those patterns as well. Okay, so let me give you a step-by-step approach to assessing the thyroid panel now that we've gone over all these patterns. So we have hypothyroidism, hyperthyroidism. Both of those have an autoimmune component. We have issues with conversion of T4 to T3, which we call underconversion patterns. And then we can have issues with the binding globulin receptors, which it's too much binding or not enough binding patterns. And we can't forget about the pituitary, where you can have a primary pituitary pattern, secondary hypothyroid pattern. Okay. So this is just a really simple summary chart to kind of go over the main concepts. We're assuming the patient has hypothyroid symptoms. They don't have to, but for the most part, you want to always consider these panels if someone has any kind of thyroid symptoms, right? All right. So if a patient has clinical hypothyroid symptoms, is it due to primary hypothyroidism? If it is, then their TSH levels are high. And at that point, you know that some of their thyroid gland has been destroyed, and they're actually now in a high thyroid deficiency state, and they're probably at the point where they need replacement to function properly. And the next question is it due to primary hypothyroidism Hashimoto's? In that case, TSH is high, and they have positive thyroid antibodies, either thyroglobulin or TPO antibodies. TPO antibodies being more sensitive. If you only have to pick one, use your TPO antibodies. Now, there are some people that actually have goiter. Iodine deficiency reduced goiters. In those cases, they actually have an enlargement, and their TSH is high. And as soon as they take iodine, it normalizes TSH. This is really, really rare. The most common cause of goiter worldwide is actually Hashimoto's. And the reason people develop goiter is because there is prolonged thyroid-stimulating hormone activation of the thyroid gland, and the thyroid-stimulating hormone starts to cause their tissue to grow. And you can also have HCG, increased thyroid gland size, and that can happen for multiple pregnancies. It can happen for people that were using HCG to lose weight. But if you have someone who's got enlarged thyroid gland, and if they're active goiterogenic state, you'll see the high TSH, you'll pop it a goiter. And then if it really truly is iodine deficiency, as soon as they take iodine, you see those levels normalize. I would say this is very, very rare. This is the most common thing. Like in your career, if you saw 1,000 thyroid patients, 999 are going to have this, and one may have this. Okay. Now, if they have hypothyroid symptoms, is it due to environmentally induced hyperthyroidism? Another thing is some chemicals may impact and cause this goiterogenic response, and that's TSH, not always iodine. Okay. Now, if it's a pituitary pattern, TSH is low and the total T4 is low, right? If it's thyroid underconversion, the TSH is normal, total T3 could be low, total T4 total T3 is low, total T4 is low, and then reverse T3 can be high. This is not converting T4 to T3. If it's a thyroid binding globulin pattern, then you can have the T3 uptakes high or low, and then metabolic syndrome I put in here because the most common mimicker of every single hypothyroid symptom is actually metabolic syndrome. So when people get, hypothyroidism, they lose their hair, they have metabolism issues, they can't lose weight, they get tired, they get fatigued, and those are identical to symptoms of metabolic syndrome. So you should always consider when someone has thyroid symptoms to rule out metabolic syndrome patterns or just some kind of dysglycemia. Okay, and then I made a chart for you here. It just goes over the basic patterns. So if we start with the left, if someone has low TSH and low total T4, then you think it's a functional pituitary pattern. If their TSH is low and their T3 and T4 is up, then they have hyperthyroid. Check all three antibodies. And if the TPO, thyroglobulin, and thyroid receptor antibodies or TSH receptor antibodies are positive, it's probably Graves'. And if just the TPO and thyroglobulin is positive, then it's probably Hashimoto's. And then just realize most people that are taking thyroid hormones are going to have a TSH that's depressed just by the fact they're taking exogenous hormones. Here you see high TSH. If the TSH is high, check to see if they have antibodies. And if they have antibodies, it's positive, it's Hashimoto's. If it's negative, then, it may not be Hashimoto's. But a lot of times, if you repeat the test, it'll show up. These antibodies do fluctuate. If they have high TSH and you palpate and they have a goiter, and there's definitely diffuse enlargement, check the antibodies. The most common cause is still Hashimoto's. And see if positive, they have Hashimoto's. If the antibodies are negative and they have an active goiter and high TSH, that's when you're thinking of like iodine deficiency or environmentally induced goitrogens that can throw off the thyroid. But again, these being not as common as the Hashimoto's. And then if you have high TSH and the thyroid's painless, that goes back into the Hashimoto's. If someone has high TSH and there's pain in the thyroid gland, it's an infected thyroid gland. That's like a viral thyroiditis. So be aware of that. And then there's some indications here for normal TSH. Anyone has normal TSH, just make sure they don't have any thyroid symptoms. If they have thyroid symptoms, if they have thyroid symptoms and normal TSH, you could still have Hashimoto's in a subclinical state. So antibodies that are positive with normal TSH, you think of this Hashimoto's pattern. And then if their TSH is normal, meaning they're not hypothyroid, antibodies are not involved, you could have a binding globulin issue. So look at the T3 uptake. If it's high or low, it lets you know what's going on with binding globulin patterns. And also if TSH is normal, but they have thyroid symptoms, they could have a T4 or T3 conversion issue. So if you look at this chart and you have a complete profile, you should be able to go through and identify all these individual patterns that can take place. And some people have more than one. Some people could have Hashimoto's and an unconversion issue, for example. Or some people could have hypothyroidism, and they also have a T3 uptake that's abnormal because they're on birth control pill and so forth. Anyways, I hope this clinical pearl and this review of laboratory tests was useful for you, and thank you for your attention.